use an Apple.
But sir, Radiant is not free.
Radiant is not free, you have to pay for it. Nothing is free. So this is free version, lasts you for 30 days trial period or something. This is paid, but this is, I think, if I'm not mistaken, I pay for this 4,000 in a year or something like that. It's still worth it. I'm not sure about the exact cost, you'll have to find out what is it. But this is like for the whole year. This is not a trial version. So once you use this, you will start feeling a lot of change in the way you read your scans. Okay. So let me run you through a small. So let me run you through some scans. I want you all to read the scans rather than me to read it. I'm just going to move it around for you all. The advantage of doing this scan in this way is you can actually make two windows. Okay, and we can have similarly over here plain bone thin, and we can change that to So now I want someone to read this scan for me. Okay, I'm going to go front to back. So someone has to read this scan, right? Is it okay on the right side? Okay. So again, coming from front, what is this?
Frontal sinus.
What is this?
Nasal bone.
Right side.
Okay. Yeah, good. What is this coming up here now?
Crystal.
The
Frontal septum.
What is this and what is this?
It's a right right frontal
Right
and left.
and left.
Right and left.
Okay. Do you know whether it's right or left, or is it just a septation? You don't know, right?
Septation.
We don't know.
Okay. But there are septations within the frontal, right?
Mm.
So you see this? What is coming up here?
Frontal beak.
Right? Frontal beak.
Mm.
Good. This is again the nasal bones. Can you see that?
Yes.
What's this over here?
Perpendicular plane with more. A palatal bone. Posterior part of the
Okay,
septum.
what I'm going to do is I'm going to ask one by one you have to answer, okay? So that all the answers don't come from me. You want everyone to answer. Come on, anyone on that side, okay? What is this over here?
Frontal view.
Okay, in the middle section. Next, what are all these now?
Septation.
Septations. This is perpendicular plate of retinal, right?
Mm.
Now here, let me also give you, if possible, sagittal. Can you see this now?
Mm.
Okay, now if I put this here, let me get to the vertical. Can you see this over here?
Mm.
I'm just showing you this on a sagittal scan as well, right? You see this over here, frontal sinus. You could see this. This is the frontal beak, correct?
Yes,
Now I'm moving this on the sagittal scan. You are like this. What do you see? Frontal beak is thick over here.
Mm.
Frontal beak is thick over here. And then what do you find? It becoming
Like
frontal recess, right?
Mm.
Is this clear to everyone?
Mm.
So where your frontal beak ends, frontal recess starts. Ahead of this, can you see this frontal beak?
Mm.
This is the front. You can still see the nasal bones, right? Keep coming back, and you start seeing the frontal recess over here, right?
Mm.
Correct?
Yes.
Can you see the posterior part of the area, and you can see this? This is all skull base,
Mm.
right?
Mm.
This is the middle turbinate, and that's the sphenoid sinus. Okay. Now let's go back to the display. Okay. Look at the center. Keep looking at the center.
Mm.
Okay. What is happening now? Frontal beak is disappearing.
disappearing.
Okay. What do you want to get there? Yes. Now you find one cell over here. What cell would this be?
Isolated.
Supraorbital cells.
No, it's not isolated. It's lesser than the half height of this. So it is a type 3 type of cell. Okay. And this is a very pneumatized
Frontal sinus.
frontal sinus. Can you saw that on the sagittal, right? You saw this very highly pneumatized sinus, right? You're seeing it over here as well. Now, once I go here like this, okay, posteriorly, what else can you see now? What is this?
Nasolateral.
Insular like
Good. What is this now?
So bulla.
Yeah, bulla ethmoid. Okay. What you're seeing is round orbit, triangular maxilla. Can you see that? What are you seeing? What are you finding over here now?
Opacity on the left.
Left side was
What are you seeing?
Opacity in the.
Why do we say it's sinusitis? It's just edema of the mucosa. Okay? Scan people report this as sinusitis. We ENT people say there is some greyish haziness. So this could be edema of the mucosa. Correct? What else can you see? Going back now. What else can you see here? This part of maxilla is,
Opacified.
whereas this is open.
Free.
This is your middle turbinate. Where is it going?
Lamina.
Pelvis. Middle lamella.
Yeah, medial and lateral lamella is going to the skull base. This middle turbinate is also going there to the skull base. Okay. What do you find in this sinus here? What's happening to this sinus? So
Widening of the
Widening. Plus there's a cell also. Sorry.
This one.
Osteum, yeah.
Halar cell.
sinus cell. Good. You're reading well. So it's very good. Now, seeing this, anyone, what is your diagnosis?
Unilateral can be
Antiquarian
AF.
Pardon?
It's a unilateral disease, mainly
One by
involving
one. Your diagnosis?
unilateral disease with mostly maxillary ethmoid complex involvement. So could be an AFRS if
Okay.
one possible.
What else?
So there is.
Chronic
Chronic
rhinosinusitis.
sinusitis with the cyanonasal polyposis. Chronic rhinosinusitis with
But the other side is quite clear. There's little edematous ethmoid, that's all. Polyposis generally bilateral. So you're looking at almost a unilateral disease, right? You know this is not a bilateral polyposis case. Rest of the nasal cavity is all clean. Though you could still have a little haziness here. You're seeing the maxilla completely obliterated, right? Ethmoidal disease will have secretions in the maxilla. And will have bilateral huge polyposis with both the sides maxilla filled up. Correct? So this one with the widening of the ostia and this sort of picture, she said is an antroconal polyp. You said is a allergic fungal. Allergic fungal generally involves both sides, but this could be a fungal ball.
Fungal ball, correct.
Okay, so not allergic, but you could say fungal ball, right? Any other diagnosis?
Inverted
Yes,
papilloma.
inverted
can be,
papilloma.
yes.
Anything else?
So DNS on the right.
Pardon?
So DNS on the right side.
I didn't understand. What is it?
Deviated septum towards the
Deviated.
right
So
side.
that's okay. So this disease could be any one of this which you have told me, right? So what would you do? Suppose you have this patient, what would you do? One by one. Anything else? Diagnostic endoscopy shows you a small polyp sitting. What are you going to do?
So
So
in
an
this.
inverted papilloma if you have.
MRI.
Yeah, that's okay.
Bio.
So the correct answer is MRI.
MRI.
Okay. I always made it a point to teach this to people. Don't rely so much on CT scans alone. This grayishness could be blockage of the ostium with just fluid inside. Okay, acute maxillary sinusitis. This could be antroconal polyp. This could be fungal disease. Though in fungal you still see some little bit of concretions here and there. You find some whitish opacities. Okay, you could have that. Or this could be an inverted papilloma. When you do an endoscopy from here, even in inverted papilloma, you just see 2 or 3 polyps hanging over there because it pushes and prolapses the mucosa. So inverted papilloma is no. And biopsy never, unless you see a fleshy mass inside. Never. Never biopsy without knowing, without having an MRI. Pardon?
After CT you can do biopsy to confirm
Never. Never. Have an MRI. Today you have the advantage of MRI. What if this is an angiofibroma and you biopsy it? What is going to happen? You'll be struggling to block it and you'll run straight to the theatre and then you'll run to investigate, right?
In CT there is finding some entry bone of posterior maxillary sinus, antral molar sign.
Yeah, I agree, but will you biopsy an angiofibroma?
No.
Okay, so why are you talking of biopsying this? What if this is a polyp? You're biopsying, you're only getting polyps. If it's an inverted papilloma, also polyps will hang out in the front. You take it, it will come as polyp, but it may actually be a tumor inside. It may be a CA inside. We don't know. CA, of course, will destroy a lot more walls. So what I mean to say is, in short, never biopsy in today's world. Even CAs of any one of the sinuses are never biopsied straight. We do a CT, come an MRI, make a provisional diagnosis, and if we feel it's a CA, then we biopsy. We never biopsy without having a provisional diagnosis in our mind. Okay? If I want to figure out whether this is inverted papilloma versus CA, then I could biopsy. Is that clear? So this is the finding. So you should always do an MRI. MRI is a clear-cut investigation, non-invasive, no problem. It will differentiate straight off all the differentials that we have spoken about. Is that clear? Suppose in this it says there is a possibility of it being a CA. Then I want to know what CA. Whether it's a squamous cell CA, whether it's an adenocarcinoma, or whether it's some other type of CA which is common in the sinus. Then I don't mind going in biopsy, because then that depends on that depends my excision versus chemotherapy, radiotherapy, etc. and so on and so on. Okay, but I will not biopsy this if it's an antroconal polyp. If it's an angiofibroma, I will not biopsy this at all. Okay, go on reading the scan now. Sorry, I'm going back here. Okay, so this is going back. Now, what is this here?
That is
Uncinate.
Uncinate process, and this becomes the drainage pathway for the
Infundibulum.
the right side.
infundibulum. So right side maxillary sinus would drain from here. Left side is completely blocked over here. Okay, you can see ethmoidal cells blocked. You can see some amount of haziness over here, right? You can see it means like whitish stuff. So what does this tell you roughly?
Fungal growth.
Yeah, it's probably fungus here. Few concretions here and there. You can start seeing. Okay, this was a case of fungus, but always I make it a point to say unilateral frontal, unilateral sphenoid, unilateral maxilla. Don't touch it till you do an MRI. Simple. In case of difficulty in diagnosis, always do it. So I've been propagating this for the last 2-3 years because of so many problems. We get a lot of patients referred to us. Someone has gone into the sphenoid biopsy and you have a huge CSF leak because the meningocyte coming down straight there. Okay, someone doing something and thinking it's a fungus and they get something else. So we have had patients coming to us like this. So better to investigate and then to think of what we really want to do. So this is how we study the scans on 3 planes. Is this clear to everyone?
Yes.
Okay, if you go further on this again, you see this is the posterior ethmoidal cells. Can you see? This,
It's become oval.
yeah, this is becoming almost triangular, where this is becoming oval. What this becomes?
Posterior.
And this remains the flat area which I told you about, fovea.
Fovea.
Okay, that's the posterior. There is some amount of haziness all over here. 2, remember one thing in CT scan I always tell people. I've had a lot of people in the ENT fraternity, patient comes to you, I have a stuffy nose, CT scan. Don't ever do that. Suppose this patient comes with only a pure fungal disease on this, but this is hazy, all this is hazy. What are you going to tell him? Fess. Right? So what does that tell you? Always first treat the patients for 2 to 3 weeks. Okay? Let all the mucosal edema get down. If you think it's allergic, give nasal sprays. If you think antibiotic required, antibiotic, decongestant, washes. Do what you want for 3 weeks. All the mucosal edema sets down and your lesion stands up. Else, if you do it